Hey everyone, welcome to another episode of Not So Serious Science, where we explain science in a way that even your uncle will understand. I'm your host, Emmanuel, and with me is my co-host, Pat.
We're so excited to have Dr. Angel Foster join us today. She's dedicated most of her professional life in studying women's health research. And recently she received a grant from the Social Science and Humanities Research Council to study COVID and how COVID affects service and availability for abortion. So looking forward to the discussion, and let's do this. Yeah, I just want to thank you for accepting so gracefully my email when I sent you an email, just a cold email like that. So really appreciate it. It doesn't happen too often, so really appreciate your time. And it looks like, going through your background, I mean, you've dedicated a lot of your professional life in terms of women's health. Obviously, that's a very important subject to you. And can you explain a little bit about, obviously, aside from being a woman, in terms of what is that, important around doing some research and your professional life around that subject area?
Sure. So I'm a global sexual and reproductive health researcher, and I actually got motivated to do work in the abortion space because of personal experiences. So I'm American, and I grew up in Portland, Oregon, which is a very sort of progressive blue city in a blue state. And I was the kid. I grew up with a single mom, and my mom used to take me to sort of Planned Parenthood rallies, and I would be the kid who would stand there with a sign that said, child by choice. And so my mom was a sort of reproductive health and rights activist. And when I was about 12, my mom sort of sat me down and she explained to me why she was so committed to reproductive rights and justice. And when she was in college, she became pregnant, didn't want to be. She was at UCLA, so she was in Southern California. And at that time, abortion was illegal in the United States. And she knew, though, that from networks, personal networks, that if she could get money together and cross the border into Mexico, she could have an abortion with a trained provider. And so she sold everything that she could. She assembled $300. She crossed the border into Mexico. But it was so common for American women to go to Mexico for abortions during this period that she was robbed at knife point when she got outside of the facility. People would just lay in wait because they knew that women would come with money and cash in hand for their abortions. So she had to go back into the US, re-raise the money, which was really difficult, went back into Mexico, was able to get a safe abortion with a trained provider. But the whole process for her was really traumatizing. Not the abortion itself, but what she had to do to get one. And so as like a 12-year-old, I decided that this is what I wanted to commit my life to doing, to work to make sure that no women would ever have to go through what my mom did. And then as I became older, and for other reasons in my life, my career took shape such that I was doing a lot of international work. I actually started to see really firsthand what it looks like when abortion is legally restricted and what that means for women, for women's health, for communities, for families. And so it just really fortified sort of my personal link with this issue was really fortified then by some of my work in the kind of public health and activist space. And what I found is that research can be a really wonderful entry point for doing this kind of work. Mm-hmm. I'm a action-oriented, policy-relevant researcher, so I take on research questions that are meant to affect change. But sometimes, data often speak for themselves, and if we can present evidence to the right kinds of decision makers, we can sometimes shape policies in ways that are also advancing kind of reproductive health rights and justice.
I noticed that you did some Middle Eastern studies as well. Mm-hmm. I guess that's kind of related to this in terms of not having access and in terms of maybe your mom's experience back then, but in that perspective as well. Was that that come into play?
Yeah, it is this kind of, they do link to each other. So this other whole part of my life is that, like I said, I grew up in Portland, and Portland was, at the time in the 80s, was the third largest port of entry for Southeast Asian refugees. And so in my family, when I was growing up, there were 17 people who lived in our house as foster siblings for periods of time, almost all of whom were refugees and displaced folks from Vietnam, Cambodia, or Laos. And so refugee issues were a really big thing in my life growing up as well. And when I was in high school, I had the opportunity to spend time in Palestinian refugee camps in Jordan. And that was actually the first time that I was, really interested in international issues and global issues. It happened to be that I went on this program to the Middle East through the National Council on U.S.-Arab Relations. And it was the first time that I ever spent time in a refugee camp, even though refugee issues had been really prominent in my family when I was growing up. And I was just immediately struck by how generous and warm and resilient people were in spite of what was, really difficult circumstances. And so I had these sort of two strains in my life, doing work in the humanitarian space, and then specifically in the Middle East and North Africa, because that was what I was sort of introduced to in terms of the humanitarian sector, and then also doing sexual and reproductive health work. And I started doing work in the region, and it was actually when I was doing work in Egypt that I really started to see the consequences of legal restrictions on abortion, and things really started to kind of come together. I will say, I do a lot of work in the Middle East still, and I do work around abortion. I do work in the humanitarian sector more broadly, so not just in the Middle East and North Africa. But I will say the most challenging place to do abortion work in my experience is actually the United States.
Right.
And
Wow.
yeah, and it has to do with how politicized abortion is beyond issues of criminalization or what the legal status is.
So how hard is it to change a policy, do you think then? I mean, interestingly, how you mentioned that, it's tougher in the US, right? But what do you think it will take, to really be able to make a change or make a difference?
Yeah, I think it's such a great question. I mean, in my experiences, policies change policy change is often both deliberate and then very opportunistic. And so you can do all of these things to kind of get your ducks in a row to shape policy, but then you need these windows of opportunity that can be really hard to predict. And sometimes it can just be as easy as having a champion who happens to be well-positioned, who takes on the issue and says, all right, I'm now going to move this forward. Sometimes it can be a more deliberate process that you have changes in a court, for example, and what happens with your justices, or that you have laws that are proposed and that build on each other. So I think it can go in a lot of different directions. One of the things that I found, and one of the big pieces of research that my group does around the world, including the work that we're doing in Canada, is documenting people's abortion experiences. And we do that in countries where abortion is decriminalized and legal, like in Canada. And then we do that also in countries where abortion is severely legally restricted, like Myanmar. And what we found is that these are not, in some ways, these are not especially interesting research questions, because we kind of already know the answers to this, which is that, in general, people who become pregnant and don't want to continue that pregnancy and are able to get an abortion that's safe, are satisfied with that, feel relief afterwards, do not regret their decisions, and it opens up other opportunities for them in their lives, given whatever their circumstances are. So in some ways, it's not, we're not surprised by the answers, but being able to actually lift up people's voices and share their stories can be really effective in policy and advocacy work. And it also is very different. If you're a politician in Myanmar and there hasn't been work for 30 years on people having abortions within the borders of your country, it may be the same kinds of stories that we hear from women who are in Thailand or women who are in Malaysia, but it's not from your own setting, and so it's easier to dismiss. So having that kind of current research base can be really valuable for policy and advocacy. So that's part of the reason that we do that work.
Have you found culture plays a big part? Like, for example, I'm maybe in the Middle Eastern countries or some Asian countries where, it's pretty much frowned upon to, have sex before a certain age or before you're married or whatnot. And so girls who do and who end up becoming pregnant, they have this added pressure to, not go because everyone's going to know versus, here in North America, it's kind of more liberal in that sense, the point of view. Have you found that?
Yeah, and it's complicated. So in some places, it's actually the premarital sex or the illicit sex that is by far the more stigmatizing thing. And so the abortion is just sort of, that actually isn't as problematic. It's really the reason that somebody became pregnant in the first place that is attached to more, whether it be community or familial or individual sort of shame and stigma, right? And that's a kind of interesting thing where it's just, the fact that the person became pregnant is just evidence that the sex occurred. And so almost irrespective of what the outcome of that pregnancy is, there's still going to be the shame and stigma that's associated with the sex. Whereas in other settings, the sex isn't as stigmatized, but the decision about what to do with a pregnancy, or maybe a pregnancy that's outside of sex, may be stigmatized. So I think those, we do see some differences. I will say that all over the world, people have abortions, people need contraception. And that is actually universal. And that's true of people who are married and people who aren't. We also know that it's not just women who have abortions. And so we talk about women a lot because that's the vast majority of people who become pregnant. But in Canada, for example, we're really moving to language where we talk about womex. So we talk about women, trans folks, gender non-binary, two-spirit people who have the capacity to become pregnant, to be a little bit more inclusive. And there can be some differences in people's experiences. And I think a lot of that has to do with how they're received by providers, how they're received by health systems, but at some level, the experiences are actually quite universal and the needs are quite universal.
So how has the whole pandemic with COVID affected abortions or the area itself? Like, has it been very restrictive in that sense? Or has nothing really changed? Have you noticed anything different?
Yeah, so really interesting and complicated question. And I'll just say that we see some very different top level responses to sexual and reproductive health in different settings. So in the humanitarian space, which is really sort of guided by some global standards, provision of certain types of sexual and reproductive health is part of what we call the minimum initial service package. So, within 48 hours of the onset of an emergency, there are certain services around sexual and reproductive health that should be provided all over the world, irrespective of the type of emergency, the type of crisis, the kind of displacement. And that really provides, I think, a kind of global benchmark for the kinds of things that should always be available. What we found, though, with COVID is that there were these discussions that were happening in a lot of global South countries because this becomes, very relevant in places where there's a lot of displacement. But then we have countries like the United States where you have a federal government that's basically come out and said sexual and reproductive health services are not essential. Contraceptive services delivery is not essential. Abortion is not essential. And you have individual states that have then used the pandemic to say, we're going to stop these kinds of services being provided because they're non-essential. Mm-hmm. And then we have Canada, where the federal government came out very clearly and said, abortion is a medically necessary service. Contraceptive service delivery is a medically necessary service. These services need to continue to be provided, but we might have to make some adaptations to the services so that it adheres to some of the physical and social distancing requirements so that it's safer for patients and for health service professionals. And so you really do see this kind of sort of wide range of responses to this. And it's been quite complicated. I will say, I think that the US messaging has really undermined, and what's happened in some US states has really undermined some of the global efforts to ensure continuation of sexual and reproductive health services. And I know we're seeing in some places that even things like maternal health services, so childbirth services, delivery services, were shut down for periods of time, which obviously has, many unintended consequences in the sense that, it's not that COVID-19 itself is the reason why people are dying during pregnancy. It's because they're no longer able to get pregnancy care or be able to deliver in a facility with a trained birth attendant or a skilled birth attendant. And so, we are really seeing this in a lot of different places, but it's a complicated question. Canada has really stood out in the way that the government responded to this.
Yeah, it's almost like a polar opposite of how the US reacted during this pandemic. I mean, first of all, I want to congratulate you. So you landed a SSHR grant on the COVID effects for abortion services and availability. Can you, first of all, what does SSHR stand for? And your proposition that landed you this funding?
Yeah, Yeah, so the Social Sciences and Humanities Research Council is one of the three tri-council funding agencies in Canada.
Yeah.
It's kind of the smallest of them, but they have a funding mechanism that's called a Partnership Engaged Grant. And so my group at the University of Ottawa is working with the National Abortion Federation Canada, or NAF Canada, to look at sort of what's happened in Canada pre and post COVID with respect to changes in abortion access. And so we're able to look at, so NAF Canada is a organization that has members of, hospitals, clinics, individual clinician members that provide abortion care. And NAF Canada members provide about 80% of the abortions in Canada outside of Quebec. So this is a robust data set that we have to be able to look at what kind of provision was happening sort of the year before COVID, and then what we see post, call it March 15th, 2020, in terms of shifts in numbers, gestational age, types of procedures. We're then doing a piece where we're really looking at WMX's experiences accessing care. And we've seen in Canada some really innovative service delivery models, but then we've also seen some facilities that have had to shut down or pare down their services because of some of not because they're required to, but because they've been trying to adapt to various kinds of physical distancing requirements and what they need with respect to PPE and the kinds of services. So some people may be traveling farther. We're trying to look at some of these kind of questions. But of course, some of the other issues that come into play is that these, COVID-19 mitigation strategies, reducing travel, the closure of the Canadian-US border, for example, to non-essential travel, also impacts where it is that people can access care. And so for Canadian women who have advanced gestational age terminations, most of those women get their care in the United States because it's such a small number of people and there isn't enough volume to have a facility that can provide post-viability or later gestational age terminations. And that group no longer can actually go to the United States, or hasn't been able to since March. So that's another population that we're really looking at what's happened with those folks.
Are there, just like your mom had to go to Mexico back then to get an abortion, are there a lot of Americans that come to Canada for the same reason these over the last couple of years, you think? And that stopped as well. So
right. So we haven't seen that, which I think is kind of fascinating. Certainly in Canada, there's a whole history of people crossing provincial borders to be able to get care during different eras and then coming into the United States. And when PEI for many years didn't have services, you would see some people from PEI that would come into the state of Maine. The challenge for US women is that most of the places that border Canada actually have, this isn't entirely true, but if you look at the states that border Canada, most of them are states that have relatively good abortion policies and abortion coverage. And so the people who are in the states that are closest, where this might become would be the most pressing, they actually are already at some place where they could mostly get care, or they could go to a neighboring state that would be closer. They'd be able to stay in their own country. They'd still have to pay out of pocket, but it would actually work out for them. It's really when you get into the deep Midwest and when you get into the South where you start to see more of these restrictions. And then it's not nearly as easy as somebody just kind of driving across a border. It actually involves now international plane travel or things like that, and that becomes a whole other complicated thing. And of course, it's poor women who are the ones who are really hit in these states because in the United States, most states don't cover abortion care for low-income women, and that's part of a federal policy. There are some states that have decided to, on their own, cover abortion care for low-income women. But again, those are blue states that are on the coast and tend to be the ones that border Canada.
So in Canada, it is fully covered in every province right now?
So abortion is a medically necessary service. So it is covered through provincial and territorial insurance schemes and federal insurance schemes. There are a few gaps in some places. It took a while for something called medication abortion, which is abortion with pills, to get covered. That was a little bit of a challenge because, well, abortion is a medically necessary service. Canada doesn't have a national drug benefit program. And so abortion pills sort of fell into this kind of interesting gray area, and it took some individual efforts at the provincial level to make sure that that coverage happened, and that's happened now almost everywhere. Sometimes there's some portability issues about being able to cross provincial boundaries and be able to get, your abortion covered if, for example, you have an insurance card from one province, but you go into another province. So there are some areas that can be gaps, but as a fundamental principle and as part of the Canadian health system, it's a defined medically necessary service. And that does mean that when I mentioned before that there are Canadian women who do go to the United States to get later gestational age care, that also is covered through the Canadian health system, as are the kinds of the associated costs with that. So it's a difficult thing to do that kind of travel, of course, but it's not the same as what we're seeing in the US, where people are now having to come up with thousands, if not tens of thousands of dollars out of pocket, or $10,000 out of pocket to be able to, go to one of the small number of facilities that's outside of their state.
Sure, yeah. I wonder how much of that decision was like a money thing, because you mentioned how a lot of the states close to the border have actually fairly easily access to abortion services. It's like, I wonder, it's like, well, no, we don't want to lose all our clients to Canada, where it's so easy for Americans to just go. So let's just, set up shop here, right?
It is a very interesting question. And I will say, given all of the restrictions that are happening around abortion in the US, there has certainly been some discussion in advocacy circles about the potential value of, like, what would it look like to create or to support Canadian clinics that are kind of right on the US-Canada border to really help, facilitate this process, right? Like, and, again, it's still trying to move women. It still would involve moving women who are usually not in bordering areas, through another state and then into it. But there has been some discussion because, of course, on the US side, the politics of abortion right now and the regulations around abortion are becoming very fraught, and there's a great deal of concern that that abortion will become more legally restricted in many places in the US in the next couple of years.
What about like rural neighborhoods and so forth in Canada? Are they still having difficulties accessing, for example, abortion services, or is it fairly available to them?
No, and there are challenges. So, Canada really does have kind of the great bones of a system for abortion care, and I want to kind of give a shout out to that as a model, but there are still real access barriers that people experience. And prior to 2017, and that is kind of a watershed date because this is when medication abortion became available in Canada through a drug regimen called mifegamizole, and I'll talk about that in a minute. But prior to that date, abortion care was by and large clinic-based. It was instrumentation procedures, so you had to go into a physical facility. Those clinics are almost all concentrated within 150 kilometers of the US-Canada border. So if you're in rural areas, if you're in remote areas, it was much harder to access services. There were different ways to kind of work around this, and different ways to sort of help people be able to get the abortion care that they needed, but it's not without complications, and there were some real access challenges. I will say that, people who live in rural areas of Canada often have to go long distances for lots of things. So it's not necessarily completely outside of people's sort of regular experiences, right? But abortion becomes a little bit different in that it's an urgent but not emergent issue. So it's not an emergency to get an abortion in the sense that you need one today, but you do need it soon, and the sooner the better from a sort of public health and sort of safety and efficacy perspective, right? And so sometimes for care, when we think about rural and remote populations, for getting care, if you've got time, you have time to get systems in place, and that can be challenged if you only have a couple of weeks that you're really trying to get care in the province that actually offers up to that gestational age. But in 2017, medication abortion became available in Canada. And so now there's a pill-based regimen. And Canada was super late to the medication abortion party. Like, this drug regimen was approved in France in 1988. It's been in the United States for 20 years, and Canada just approved. Yeah, and Canada just approved it in 2015, but it only became available in 2017. So it's really, it's just a couple of years. But Canada has like leapfrogged over other countries in terms of integrating this drug regimen into the system. And now we're really starting to see that this can be provided in many more areas, particularly through telehealth systems. And now COVID-19 has really jump-started some of these demedicalized or streamlined service delivery models. You can get these, with a prescription, you can go and pick up these pills at a pharmacy, at a regular pharmacy. And so now you can be in a smaller town or a more remote area, and you can have a consultation over the phone or over Zoom or online in some way. And then you can get medications from a local dispenser, a local pharmacy. And that's a very different thing than having to travel, to Toronto or the GTA area, something like that.
So why did it take so long for Canada to approve this? And I guess one step back is what are the various options available right now to women for an abortion? Because prior to this drug, what was the method?
Yeah, it's a great question. So in Canada, historically, when we think of abortion, we think of instrumentation procedures, and the one that's the most common in the first trimester is what's called an aspiration abortion. So it's using an instrument to remove the contents of the uterus. And that's what's been the sort of standard, that has been a standard way of providing abortion care for decades. In the 1980s, there was this interest in developing a medication-based model, and this happened out of a French pharmaceutical company called Roussel-Clef, and they ultimately developed a drug called mifepristone, which is sometimes known by its drug development name, which is RU486. So you might have heard of that drug. It still is something that is in a lot of kind of popular culture and language. And that drug, in conjunction with the second drug, is actually very effective through the first 10 weeks of pregnancy. And it started to roll out in a lot of different countries. Canada was part, there were Canadian facilities that were part of the original sort of North American clinical trials. But mifepristone never ended up getting registered in Canada. And part of it has to do with Health Canada's sort of regulatory processes and what drug companies actually needed to put forward and the expense that was associated with that. Some of it was just, Canada's a little bit of a tough market. And I'll say that there were some comparable things that happened in Australia, which is like really big land areas with a relatively small population. And so finding pharmaceutical companies that really want to champion this and kind of move it forward when it's not sure what the sort of financial compensation is ultimately going to be, and sort of that, so that becomes a kind of complicated piece. In BC, providers started to use a different medication called methotrexate for medication abortion, and it works well, but it's not sort of as good as the mifepristone misoprostol regimen. There's some, can't use it as long. There is a subset of people who are going to have to come back for kind of what we call serial surveillance. So, it was a kind of suboptimal medication abortion regimen, but can be great for some patients. So about 4% of abortions in Canada prior to mifepristone's approval were with this methotrexate misoprostol regimen, but it was almost all out in BC. So really we saw these instrumentation abortions, or sometimes called surgical abortions, was what was the standard. And then we see the introduction of mifepristone, and within just a couple of years, mifepristone is now over 15% of all abortions in Canada are taking place with this drug regimen. We think now it's probably up to almost 20%. I mean, it's just a tremendous shift that has happened in a very short period of time. And when you take into account for the first year after the approval, most provincial insurance companies didn't fully cover mifepristone. It's really been even a shorter period of time that it's actually become available, meaningfully available. So it's pretty remarkable in terms of that shift.
Are there any side effects with these drugs that, compared to maybe the physical method? Or, I mean, I can, just thinking about it, I think, most people may opt for the drug because it seems like it's more simpler or less invasive per se, right? I'm just wondering if there are associated side effects or not.
Yeah, so if we take, mifepristone, misoprostol, and we take it in this early period. So within the first 10 weeks, we have the effects of the abortion itself. So there's bleeding and cramping. Those aren't side effects. That's what happens when you have an abortion, right? And that, the amount and the duration is greater, the longer you're pregnant. So it's different between 6 weeks and 7 weeks, 7 weeks and 8 weeks. The real sort of, this regimen works about 98% of the time. And it's that when it doesn't work, what you usually have is a continued pregnancy. And so then you may need to have an aspiration procedure to evacuate the uterus. Sometimes you can take more misoprostol, and that can result in the termination. When there are complications, there are things like heavy bleeding. Sometimes people, very rarely, but sometimes people would need a transfusion. Sometimes those kinds of things happen. It's rare. This is a quite safe regimen. And it's certainly safer than carrying pregnancies to term and delivering. So the safety profile is pretty good. There's a relatively small number of complications, the biggest one being allergies. But overall works quite well. Side effects tend to be transient, but when it doesn't work, there needs to be follow-up and some kind of management.
Okay. Oh, so you also do some research on contraception.
Yeah.
Right. What can you tell us a little bit more about that and how what kind of focus you have on the contraceptive side of things?
Yeah. So I have done a lot of work around emergency contraception in particular. And I do that work in a lot of different places, Canada being one of them, but looking at how to make emergency contraceptive pills more available and how to increase access to the postcoital use of the intrauterine device, so that you have it both to prevent pregnancy from an individual act of sex, but then you can have a bridge to ongoing contraceptive benefit, or a bridge to ongoing contraception. So I do a lot of work around that. A lot of it is around, so one of the things we've done a fair amount of work on multiple countries in the last few years has been looking at sort of actual real world access to emergency contraceptive pills. And we do this through a series of mystery client studies. So in Canada, and there are some distinctions with Quebec, but in general, in Canada, progestin-only emergency contraception, or Plan B is the brand name that most people know it as, is supposed to be over the counter, meaning that I can walk into a pharmacy, I go to the shelf, I pick it up, I pay for it. I don't have to talk to anyone. I don't have to show ID. I don't have to, give anybody information about my health history, because it's incredibly safe, right? There's never been a death associated with the use of emergency contraception with progestin anywhere in the world, right? So it's an incredibly safe thing, and that's why it's available over the counter in so many countries. But what we find in about half of places in Canada is that it's actually held behind the counter. So it actually does, in real life, it requires somebody go to the pharmacist, actually ask for the medication, and then that pharmacist can be a gatekeeper and can either ask intrusive questions or could potentially deny provision, or can be a source of information, which can facilitate, appropriate, accurate use of the medication. But that's one of the things that we do a lot of work on, like what's actually happening with emergency contraception access. And I'll just say that for, some people, and I would say especially for younger people, having emergency contraception behind the counter can be a real barrier, because now they have to go and talk to somebody about the fact that they've had sex and they now want to do something to prevent getting pregnant.
Yeah, that's interesting. Because like you said, it is an over-the-counter drug, right? So you don't really need a prescription or anything. But yet, I do understand how pharmacists want to play a role, because they want to make sure the patient understands everything they need to understand.
And you mentioned rural populations, and that's one where we know, like, if you're in a rural area and there's only one pharmacy, right? And, you go to your nearest pharmacy, and then if you have to interact with somebody and ask for that, like, they might know you, they might know your family, they know what school you go to. And that can be really that can be really intimidating, especially for younger people, in a way that, if you're in GTA or if you're in Ottawa and you can go to one of many of the, chain pharmacies that are around, it feels different.
That's so true. Yeah. Coming back to how COVID is impacting abortion services. So as you're saying, the services are still ongoing, right? But because of COVID, is it safe to say that there are less abortions being done? Therefore, are there some women and girls missing out on some? And then it'd be interesting to see like what is that impact on that on that portion?
Yeah, this is part of what we really want to look at with this SSHRC grant. I think the short answer is right now we don't know. Anecdotally, we do know that the closure of the US border has resulted in some challenges for a small set of women. And we think, based on some sort of anecdotes that we have from certain hotlines, that there may now be a small group of people who have effectively not been able to obtain the abortion that they want and they've carried to term. And so that's a population that we certainly want to hear from and to learn about their experiences. In terms of whether or not what's happened with abortion numbers, this is complicated. And I think we'll get the information from kind of NAF Canada and the clinic providers, which will give us some information about what happens. But how we interpret that, I think, is complicated because it's not clear how COVID might be influencing pregnancy intentions. So you can imagine that because of all of the stressors that are happening in COVID, right? The financial stressors, the familial stressors, all of that, you can imagine a scenario where actually people have a less desire to be pregnant and to continue to be pregnant, right? So you actually may see greater demand for abortion services during this period because of this shift in pregnancy intentions. And that often happens with, times of economic uncertainty, right? This isn't a good time for me now to bring someone into the family. The fact that people are have for long periods of time been kind of trapped at home also means that, people may be at risk of pregnancy, like they're with their partners or so that could be true for certain people, particularly those who cohabit. But for people who don't, we don't really know what the effect of COVID has been on having sex more generally, right? If you're not cohabiting with someone, and there's been a lot of lockdown procedures and there's been a lot of distancing, it may be that we're actually seeing sort of less sex happening within certain kinds of couples or certain kinds of relationships. And so that could actually mean that you're just having less pregnancies. So I think there's a lot of things that can be kind of going on. Adolescent stuff is also complicated, right? We think that probably, on the one hand, adolescents probably have less access to contraception during COVID because things are farther, things are closed, it's harder to navigate. They're not getting necessarily services from school health programs or things that are associated with schools if they're doing remote learning. But at the same time, it may be possible that teens are having less sex because they live with their parents and now they have less opportunity to go out and hook up with people, right? And so I say that as just I don't know which of these things are happening. I imagine they're all happening. And it means that what we see could actually be really complicated. And it could all just kind of come out in the wash where it's just actually the abortion numbers have stayed the same, but we've actually had these huge dynamic shifts. So we're gonna have to really dig into that a bit more.
I actually read this thing, even pre-COVID, that teens are actually having less sex than way back because of all the stresses of social media and all that. So it's pretty interesting. Have there been long-term studies in terms of if you take a look at states that, where abortion is really frowned upon or not available at all versus countries or states that it's readily available in terms of the well-being of the woman in that area of the country or society, growing up with the child that they had to have, but they didn't really want, and all that versus, someone that feels empowered to make a decision. Have there been studies like that or?
Yeah, I have a colleague who's at University of California at San Francisco, and she actually did a long-term study that was called the Turnaway Study, and it was US-based, and it looked at what happened to women who were seeking abortion care and who were turned away from a clinic or basically looking at, clinics have gestational age cutoffs, and sometimes that's clinic specific, and sometimes it's about the state or the region you're living in, but was able to compare people who were able to get the abortions that they wanted right before that gestational age cutoff, and then compare that to people who were turned away, and was able to then look at what happened with people who were turned away, and were they able to find abortion care elsewhere? Did they just carry an unwanted pregnancy to term? And here, I mean, and there's a huge body of work, and she's just come out with a book that's really that really provides some detailed accounts of this. But the overarching message, I think, of all of this is that for people who carry pregnancies to term and have unwanted deliveries, there are negative sort of social consequences, particularly economic consequences that can come from that. And there's stressors. Over time, those things kind of even out. But I think one of the things that this really did show is that when people seek and want abortions, it's important that they get them for their mental health, for their familial health, for all of these different reasons. And that really comes out in this turnaway work.
Okay. Yeah, you would think it does make sense.
Do you think eventually one day, I guess, we'll be able to get abortion pills over the counter at a pharmacy? Do you see that as being? I guess you support that.
Oh, I do. But actually, it's such a great question. So my group just received a multiple year grant from a very large anonymous foundation to work on a multi-pronged strategy to demedicalize medication abortion in Canada. And our goal is within 5 years that in at least one province will have mifegamizole available behind the counter. So, and we're really shooting for behind the counter rather than over the counter. So moving it to a Schedule II status drug, because if it's behind the counter and you have a consultation with a pharmacist, it would still be covered by territorial and provincial insurance schemes. If it moves over the counter, people have to pay for it out of pocket. And this drug regimen costs $300. And so, and we did see this with emergency contraception. We saw this with Plan B, which is that all the advantages of being over the counter aside, it still costs $30 out of pocket. And that can be a lot of money for people as opposed to it being covered. In Canada, of course, contraception is covered for some populations and not others. So it's more of a mixed bag. But because abortion is covered for everyone, this issue, and because the pills are expensive, making sure that it's actually covered through insurance is really important. So our vision, and we are doing a series of studies to support this regulatory ask, is that you could go into a pharmacy, go to a pharmacist, sit down, in a kind of private space. There'd be a very short intake. And if you were eligible, you would be able to get mifegamizole right there, and you'd be able to take it. So you wouldn't have to do blood work. You wouldn't have a pelvic exam. You wouldn't have to do an ultrasound. But you'd still have it be covered through the health system. And that then you would also be given information about sort of who to follow up with and how, if you need it. But most people can manage this on their own. So that's what we're really kind of working for. I think in other countries, there are some efforts to move over the counter, and those are ones where maybe the health system doesn't pay for abortion in the same way, or there can be other ways of subsidizing it. But I think in Canada, having it BTC is really the goal.
Wow.
At least for now. It's a very radical reimagining of what could happen with abortion care.
Wow. That's cool. There's hope. That's awesome. Yeah. I mean, I got to say, for the life of me, I would have never thought that I'd be talking about abortion for close to an hour by the subject. Right? So I thank you so much.
Thanks for inviting me. Thanks for including me in this topic on your show. I really appreciate it. This has been really fun.
Is there anything you want us to highlight for you? Like, are you speaking anywhere in the near future, or you have a book coming out?
My colleague Lisa Wynn and I do have a book that'll be coming out next year that's on the global journey of mifepristone, and it tracks that drug's the journey of that drug in 14 different countries, and looks at starting with France and moving. The first chapter is on France, and then the last chapter is on Canada, sort of really consistent with this chronology to look at kind of what's happened with that drug. And it's an edited volume, and then we've got contributors from all over the world. So it's a really fun project.
Have you picked the title yet? Can we say the title, or is it that's?
I do have the title. I want to make sure that I get it right. This may be one of those things that we edit, but yes, it is. Abortion, Politics, and the Pill That Promised to Change Everything, the Global Journey of Mifepristone.
Wow, cool.
Nice.
Very interesting.
That's being released early next year, you said, or?
I'm gonna go with COVID-19 delays. I'm gonna go with mid to third quarter of next year as my guess. There's just been a lot that gets delayed during this period.
Well, I got to tell you, we're once we post this video up, we're going to be expecting some pretty colorful comments.
I can imagine.
We're not going to let it stop us. I mean, this has to be talked about. It has to be highlighted. This is an issue that's not going to go away. And like you said, it's very important.
I appreciate that. I appreciate that a lot.
Yeah. So thank you so much, Dr. Foster. It's been a pleasure having you. I've learned so much.
All right. Take care.
Hey, take care. Yeah.
Bye.
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 Thanks for watching. We really appreciate it. Please click on a couple of these videos for more science talk in a way that your great uncle can understand.